since I've got a microphone in front of me, I can ask, the significant outcomes that you have, sort of thinking about your own interventions as well as what we've heard today. What do you think are some of the key elements for those clinically significant, is it having a nurse practitioner embedded in a primary care practice? Is it targeting the intervention to a particular type of caregiver, care recipient diet? I'm just making stuff up, but what are some of the key elements to success, do you think? We'll start here to my left.
Well, I know one common theme is that the care coordinators who have this long-term relationship with families, that support that is there, even when there's not a lot of direct communication, is identified by families as important to them. So there's the sort of supportive side to it, but there's an awful lot of giving of information and directing people. People are very confused by the cadre of community services that are available. They have trouble talking with their physicians. Simple things, preparing for a doctor visit and then debriefing after a doctor visit. Getting another family member to do something that they would not otherwise have done. Really small things can make a big difference. So these are the kind of reasons that we see the impact on care-related strains and I think readmissions as well. In addition, one thing that's a little different about our findings consistently across the different studies from some of the things we heard this morning is that this intervention appears to have the strongest effects for people who have the most problems. And one of the things that we see almost no effect when people don't have problems, which isn't really surprising to me. It's hard to decrease depression when there isn't depression that's been elevated. So, but that is a pattern. The greatest benefits are for the care receivers and the caregivers who report the most difficulties at the time they begin.
So I think in our work, I would say that I think the nurse having the ability to be flexible and determine working with each patient and family member individually and designing the plan of care that works best for them for the time frame that's best for them. Because the intervention isn't, it's 12 weeks for everyone. It could be 4 weeks. It could be 6 weeks. On average, it's about 2 months. But it allowed the nurse the flexibility to determine how many visits they needed, how much phone call follow-up they needed. This was a 7-day a week, or it is a 7-day a week service. There is somebody available by telephone 7 days a week. And I think having the nurse be able to be there immediately within 24 hours, right after the hospitalization, to sit down with them, make sure they have the pieces, everything that they need in place as best they can, or help coordinate to get that in place, making sure they have their medications, the right medications, not too many of those medications, and being able to then follow them to the first doctor's visit and communicate with those providers, and allowing for that the nurse to be a point person and an advocate for them, as well as to teach the caregiver and the family member how to be, in this case mostly the caregiver, how to be an advocate for themselves and their relative. We saw that a lot with our intervention with patients with cognitive impairment.
Well, I would just echo that it's the person. I mean, it's somebody that's going to come and talk to you face to face, that's going to touch you, that's going to emote that they care. And what we get asked a lot in trying to implement this is, does it have to be an advanced practice nurse? And I don't think it does. I think like you've seen in some of the other models, there's some things that an advanced practice nurse can do that, say, an MSW can't, and vice versa. And if, depending on who you're having as part of your team, then you might have to backfill in some other expertise or service that whoever that person is. In the when we were putting together the CMSI proposal, we went to our simulation lab. There's a woman that runs our simulation lab. She's got a background in education, and we literally told her we wondered if there was a Florence Nightingale scale. Like if I had 100 applicants, could you run them through something and say, there's a Florence and there's something else? because I think if you, we all have had these people on our team where you're like, gosh, I don't know if she's the intervention or what we're saying she's doing is the intervention. And there must be a way to send people through some kind of simulation test where you would know, and then you wouldn't spend your time with the skill development. You know, it's like, because I think the skill development for a lot of the stuff, again, if you've organized it appropriately in terms of what services they're allowed to do and what they're not, lots of people could learn these skills except that caring part.
And did either one of you have any comments about which type of dementia, which type of family situation would be most benefited by your interventions, or is it pretty much, since they're individually tailored, pretty much anybody can benefit? Do you have any thoughts about that?
I think if you look, the only thing you can say, like if we specifically talked about our clinical trial, the only thing you can say directly is that it applies to the people that we brought into the clinical trial, who were people that met criteria for Alzheimer's disease, but they had vascular dementia as well, or they could have had diabetes, COPD. I think that the other sort of ancestry of the literature that I didn't mention, which I think you heard a lot about this morning, is tailoring interventions. And well before our project, I think people already understood for behavioral interventions, you're going to tailor them, and that you need to tailor them because you don't want to give people something that they don't need. But we don't have any more in the practical application of this, any exclusion criteria. And you do have very wide variations in the dose that they're getting.
Yeah, the only thing I would add to that, thank you, is that, you know, this is a very, the patient population we were dealing with was a very complex patient population, meaning that they had, you know, on average 5 chronic conditions or more. Many of them had more. I think the range was 1 to 13 or so, and a lot of medications. And it's complicated by having cognitive impairment. It's just one more added problem, regardless of whether they have a diagnosis or yet or not. And these complex situations require complex, tailored intervention. So I don't think that we could tease out necessarily what piece of the model worked best yet with this population, but everybody who got the high dose intervention seemed to have worked.
One of the things that I think Dr. Bernard, I don't think she's still here, but one of the things she mentioned in the last session was that in a side conversation I had with her, that that it's important that the interventions be something that demonstrate some kind of clinically significant outcomes, some kind of cost reductions down the way. But another thing that came up was the ability to have sort of an off-the-shelf product that doctors could learn about and make referrals, at least in the primary care situation. So your interventions, at what stage are they able to be off the shelf or something that, and what would you see some of the challenges or facilitators of getting the more of the mainstream healthcare system involved in these kinds of things?
Well, we've had the benefit of many studies, many years, to develop a very standardized protocol with a computerized delivery system that's very easy to use for people who aren't very computer savvy, but it is very protocol based. So there's a very strict regimen of contacts that have to be made, and there's a strict regimen of sending families summaries of information and action steps, and it's all built into the system. So with a push of a button, reports are generated for administrative purposes, for medical records, for the consumer. And I feel like that is very, very important for maintaining the fidelity of these kinds of things. So especially when you have an intervention that can be tailored. I mean, by definition, that means there's going to be a lot of variability in what is delivered to an individual or across individuals. And that is true in this intervention. I mean, I could tell you some of the most common things. The number one thing that people get help with, when I go into the records and look at the content, it's all about accessing and using services. Not all, half the stuff in there. But, what was I going to say? Well,
We've got plenty of time.
anyway, very protocol driven, and when you have a tailored intervention, you really need that. Otherwise, I'm not sure what people get. So,
Yeah, no, I would echo that. I think from our experience, we developed a patient screening and recruitment tool that was very standardized in terms of being applied across the board to everyone and can be easily adapted. And we're testing it now in other types of ways to determine, who this high-risk population is with this added component of cognitive impairment. We've also designed online training. We have a web-based training modules to orient our nurses, and we have had people who aren't nurses taking these trainings right now, social workers, occupational therapists, physical therapists. I think we've had some people from some chaplains take it, and it's really just about understanding transitions in care and the complexity of it in different settings, but it also really focuses on the evidence-based model that we've designed. The importance of documentation is really critical. I think that's something that's really worth pointing out on the quality monitoring. It's about the fidelity, and there are some things with our model that are easy to check. I mean, did the patient get seen within 24 hours of enrollment? Were they seen within 24 hours of being discharged from home? And if not, why? And understanding that, and or if they had a hospitalization, really sitting down and looking at that. One of the things that we embed in this model, and when it's being implemented, is a sort of every other week the nurses get together, even still in our service line, they get together and they sit down and they talk about the cases that they have ongoing, and any hospitalizations that they might have had and why, and they look at the root cause analysis. Was it preventable? Was it not preventable or avoidable? And it's grounded in this root cause analysis, and really a constant evaluation of how things are going on a regular basis to look at, are we meeting our goals, whatever those goals are that you set out for yourself. If it's 30-day readmission rates, that you're looking at that for your patient population, and ideally it's beyond 30 days that you're looking at, but that is something that people obviously are very interested in.
The manualizing the intervention has been done for this intervention. It's relatively easy to do because you started off with a research protocol anyway. And so making it pretty, making it understandable and, in a binder, it takes some time, but we got local philanthropy to support that. That's, I think, relatively easy. If I had 1 million of them and shipped them out, they would just go on a shelf somewhere and gather dust. That's the easy part of it. The hard part is it really requires a cultural change in the primary care practice. Even the notion that the doctor's part of a team that includes this advanced practice nurse. It requires some physical redesign of their practice. So we've already moved the nurse practitioner's office out of primary care. In that timeline that I showed you, real estate in the primary care office just went off the roof. There's no way they're going to turn over one of their rooms to you for, care management for dementia. You're going to sit in there for an hour. So we've moved a lot of it out of primary care and into the home. The other thing I would say is, if someone says, we'd like to do this, do you have the materials? Then what you usually say is, well, we have the materials if you're ready. And they say, we're ready. And then you go, no, here's what I mean by ready. And I say what I said. And I think that's by far a bigger barrier.
And so, given that all of your interventions have standardized protocols and very sophisticated methods of and consistent methods of operating. What are some of the issues around financing, thinking about people's willingness to pay privately, thinking about Medicare fee-for-service, and thinking about Medicare Advantage? I think those are all separate dynamics. I know that's a lot to think about, but go right ahead.